Can see everything. My name is Nikita, like Emily said. I'm a fourth year medical student at Northwestern, and I'll be talking today about something that I've been working on at Northwestern. It's specifically about how we use race categories like Black, White, Asian, the things that you check on a box about yourself in our medical calculations. I'll specifically be talking about this as it relates to kidney function. So please, like Emily said, feel free to ask questions at the end, but if there's anything very unclear, feel free to also stop me along the way. Okay, so to get us started, I wanted to start with a couple of questions to hopefully make this presentation feel especially relevant for everyone. So I want you to all think about whether or not any of these things apply to you. So have you ever had your kidney function evaluated by a doctor or a nurse? Have you ever taken medications like metformin for diabetes or lisinopril for blood pressure control? Have you ever received IV contrast for imaging? That's where they inject a little bit of contrast to help illuminate vessels in your body as they take an X-ray or CT scan. Or have you ever had a family member or friend who's been on dialysis? Maybe you have been on dialysis before, or do you know anyone who's received a kidney transplant? All of these things are related to one of our most important organs, and that is the kidneys. So as many of you I'm sure know, we have two kidneys, most of us, some people have one, and they are located just in our lower back, and they perform some very important functions in our body. They do things like help remove medications that we've ingested after they have sort of performed the function that they need to in our body. They help us also remove toxins from our body. They regulate our blood pressure to make sure that's well controlled. And then they also regulate the balance of water in our body. So things that are really quite critical to our ability to remain healthy and sort of go about our day. And then how do they work? So this is the sort of bean-shaped kidney in full. If we take a little piece of it and look at the smallest unit of the kidney, we'll see this sort of collection of blood vessels and then also these tubes. The way that the kidney excretes toxins or excretes water or excretes our medications is by connecting to the bladder through something called the ureter over here. So we basically have blood on one side, just running through our veins and arteries. And then adjacent to our blood vessels, we have these tubules that then collect the waste and then finally bring them to our ureter and then to our bladder. And so we really have focused on the glomerulus, which is this sort of knotted collection of vessels, and that's where a lot of the filtration happens, where we push out the toxins and the medications or whatever else into these tubules. So when we're thinking about whether our kidneys are working, we're really focusing on the glomerulus here and trying to figure out if that unit itself is working. And the ways that doctors determine if the glomerulus, that part of our kidneys, are working is really through an estimation. We unfortunately have a lot of trouble measuring the kidney function directly. The only way that we're able to do that is through something called iothalamate. It's very hard to, it's logistically very difficult to give it to a patient, and then also very expensive, so not very useful on a day-to-day basis when you're maybe just going up to your primary care doctor and wondering how your kidneys are doing. Instead of being able to measure it directly, we have to use an estimation. And throughout the time that medicine has existed, people have tried to come up with good estimation techniques. And everyone has come up with a different set of equations to try and estimate our kidney function. The ones that are most popularly used now are two that I've listed here: the modified diet and renal disease equation and the chronic kidney disease epidemiology equation. Those aren't super important to know, but I listed them here just in case you hear them in your interactions with healthcare providers. But both of these equations take the same variables. They take something called our serum creatinine, which is a breakdown product of muscles. They take age, They also have an input for sex, either male or female, and then they also have an input for race. And the options for including race in this calculation is Black or white versus white and other. So white and all other races aside from Black are categorized the same. Depending on which equation you use, whether someone is put in as Black or white changes the outcome of the equation differently. If someone is put in as Black in the MDRD equation versus in the CKD epi equation can increase the output value by 15 to 20%. So that's to say a Black patient with the same variable serum creatinine, age, sex, who's marked as Black, has a kidney function that seems 15 to 20% better than a white patient just because of their race alone. So when I first found out about these calculations, I was really surprised. As someone who is a South Asian woman, I identify as Indian. When I check the race box, I identify my race as Asian. I was like, where do I fit into this? I'm not Black, I'm not white. What would my modifier be? And also, this is something that's being used for all of our patients. Like I said before, we need to know someone's kidney function to decide whether or not we can prescribe them a very common drug like metformin. It's also really important if we're trying to decide whether someone should get contrast in their imaging or not. So we're using it everywhere, but we have these sort of fuzzy boxes where some patients fit into Black and white pretty clearly, and some patients don't, like me, for example. And that one decision where we're deciding what we think their race is then impacts what the number is by up to 15 to 20%, a pretty big change. So I think that's my point about these fuzzy boxes. To elaborate on that a little bit more is to say that race is complicated. I think the intention originally in including race in these calculations was to help us sort of give a doctor some idea about ancestry or genetics, these underlying sort of deterministic factors that each of us have. We were trying to use race as a proxy for that. But what we know now is that there's actually more genetic variation within a racial category than across racial categories. So for example, two people who identify as Black don't necessarily have more similar genetic material than someone who's Black and someone who's white. Furthermore, how do we use this set of boxes consistently? Does my definition of Black match your definition of Black? And how do we categorize people who are biracial or multiracial? Biracial and multiracial communities are the fastest growing group in America today. So how do we put them in these boxes too? And then finally, who determines whether the race adjustment factor is used? Is it the patient? Is it the doctor? Is it the lab? Is it the people who read the imaging? Everyone is doing this differently. And so I would say race is not just complicated, it's also an imprecise variable to be using when we want a really precise number to come out of these equations to help us make really sound judgment calls about someone's kidney function and therefore whether we give them a drug that they need, whether they're able to donate a kidney to someone else. We also see, so these equations have been retested on different populations than the original ones that they were created on. So for example, this paper, it showed that if we take the same equation and remove the race variable, we see the outcome here. It performs better, and we see that because this is sort of a tighter scatter plot. And I should tell you, this side on the left is that equation with the race variable included, and on the right side, they took the race variable out and then retested the equation on nearly 4,000 patients. So on the left, we see it's a little bit less of a tight scatter. And then here on the right with the race variable removed, it's closer to the line that shows us where that equation actually lies. They also, of course, did some mathematical modeling, a little bit more complex equations to also prove that. But I think it's important to recognize that just because this equation worked and was fitted very well to the original population that it was used on, it doesn't necessarily apply to it's not generalizable to other populations today. And removing the race variable is not just something that is kind of theoretical, it has very concrete impacts on patients. So another study looked at a group of 9,522 Black patients and took their kidney function that was calculated with the race coefficient, and then they removed the race coefficient and saw whether that changed anything for these patients. And what they saw is because of the removal of the race coefficient, a number of things changed for them. The patients with the race coefficient removed had greater rates of diagnosis for chronic kidney disease. That's when your kidneys stop working and potentially could lead to something like transplant or dialysis because the kidney is not able to perform the functions that it needs. They also saw that with the race coefficient removed, those patients became ineligible to donate a kidney. So right now, that means that all of those patients might be eligible to donate a kidney, but that kidney might not necessarily be appropriate for donating. We're sort of inflating the function of the kidney by including this race modifier. It also meant that more patients were eligible for medical nutrition therapy, things like access to a dietitian or access to healthy foods that would help them with their kidney diagnosis. It also meant that they also saw that removing the race modifier increased eligibility to see a nephrologist, someone who could better be able to diagnose any kidney problems. It also increased access to kidney disease education so that patients could learn more about what their kidney disease meant. And it also made patients more eligible for a kidney transplant waiting list. If any of you have ever known someone who's been waiting for a kidney, you know that it's a very complex process, taking many months. There's a number of lab tests, social work evaluations, a lot of steps that go into being eligible for a kidney transplant because we have so few available. And so many patients spend months to years on dialysis, which is where they're hooked up to a machine to replace their kidney function. And so if you're waiting more time for a kidney transplant and remain on dialysis because your kidney function seems better because of that race coefficient, that means that you'll spend a longer time waiting for this very life-saving treatment. So these race adjustment factors are not just are related to kidney disease. We also see them more broadly in medicine. There's calculations for heart failure, which is when your heart stops working, that are based on race as well, that include a race variable in their calculation. Our calculation for lung function, whether or not, how well the lungs are working, includes a race variable. Our risk scores to determine whether someone is likely to experience a fracture also includes a race modifier in it. So despite knowing now that race is this imprecise variable, it continues to be pervasive in so much of medical decision-making and then has really reverberating effects on what patients experience and their health outcomes. So a couple of things that I want to reiterate. One, very basically, our kidneys perform some important functions in our body, including clearing waste products, clearing medications, maintaining our blood pressure, and maintaining the water in our body. The way that we measure kidney function is through an estimation called the glomerular filtration rate. The equation that we currently use to estimate GFR includes a variable that categorizes a patient's race. But we know that race is an imprecise variable that does not accurately represent ancestry or genetics, something that we're trying to sort of proxy. And then including race in clinical algorithms, like in the calculation of GFR, is imprecise and really has a reverberating effect on Black patients. So I want to end with this quote, which is that race as we know it has no deterministic biological basis, All the same, race is so powerful that it can have life or death consequences. This is a quote from Dalton Conley, who is a sociologist and professor at Princeton. And I think this quote really, to me, represents the fact that race, as we've talked about, is something that is imprecise, but at the same time, in medicine, the discipline that I feel like I'm most well versed in, has reverberating effects for patients, and we often don't know about them. And often those effects, like when we're thinking about transplant and dialysis, really do have life or death consequences. So I'd love for any questions. Feel free to ask me anything about the just covered.
Can you hear me?
In case anyone wants to.
Can you hear me?
Yes, I can hear you.
I can hear. Okay. The last slide on the takeaway slide. The last line on the takeaway slide, including race is in price and has reverberating effects on Black patients. Ties to the next one. Is that kind of a knock on the pharmaceutical industry that they're developing too many drugs for white people and not for Black and others?
No, actually.
We're biasing the research.
So that's a really good question. So I wasn't necessarily talking about the development of drugs. I'm actually talking about specifically kidney function. So I think the drugs that we have that I'm talking about here are really commonly used both for Black and white patients. So I think your question about drug development is a very good one, and maybe one that we could do a whole nother talk in. But what I mean by this last point is that because we're using this calculation that includes race within it and makes someone who is Black have a kidney function that looks better, even though it may not be, it means that we think their kidney function is better, and so we don't, make sure they have access to a nephrologist or are on the transplant waiting list as early as we might for a white patient, because according to this calculation, all other factors equal, a white patient has a lower GFR or poorer kidney function than a Black patient would. Does that make sense?
It does, but you haven't satisfied me that you're satisfied with the pharmaceutical industry giving enough attention to races other than white. Now, that's not a fair thing for you to defend, but that's a concern I have after you raise these issues.
Definitely, and I totally agree with you. I think there's many, for example, if we think about sickle cell is a disease that primarily affects Black patients, and there absolutely has not been enough research and investment in thinking more about how to have creative and really effective solutions for a disease that primarily affects Black patients. I absolutely agree with you.
I do have one more question. Others may have questions, and that goes back to, you say you are a medical student. What does that mean? Are you pre-med? Will you likely become a doctor? Will you likely become a research person in the pharmaceutical industry? For people, not you specifically, but in your program, where will you think you're going to end up?
That's a great question. So I'm in my 4th year of medical school at Northwestern. So I finished college, and now in a couple of months, we'll graduate from medical school and start residency. So at the end of May, I'll have my MD and start practicing as a doctor in training. So the other students in my program are also graduating and will soon be physicians. We're going to all sorts of specialties, people who are going into internal medicine, surgery. I'll be doing ophthalmology, so I'll be an eye doctor. There are people who are doing OBGYN, runs the gamut.
How many years before you become an MD from where you sit today?
Just 1 month.
You've been practicing 9 years? She's interning right now.
You're interning now. You're more than a student.
She's in medical school. She's in medical intern. Yeah.
Okay.
In a month.
Wow. No, I thought you were going to school student, studying these things. So you're almost a doctor.
Yep. Yeah, I'm pretty close. Pretty close.
Okay.
Congratulations.
Congratulations.
Thank you.
I apologize for underestimating you.
Oh,
My only question is, you mentioned not only the kidneys, but also the lungs, the heart. So in other words, are you saying that there is a large discrepancy in the medical world among different ethnic groups? In
Will you say
treating,
that question one more time, just a little bit more loudly?
you're talking about the kidneys, but then you show there's a difference in bone breakage in the heart and also in the, well, the heart, the lungs and the bones. So are we treating, are all patients starting off being treated similarly, or should they all be treated differently according to their backgrounds?
Yeah, I think that's a really good question. So I think what you're getting to is, for me, is there ever a time where using race is appropriate in clinical calculations? Because right now, as you said, in all of those disciplines, there are clinical calculations where races are treated differently. And there are a number of writers who have written about when is race appropriate. And one of their biggest arguments is that we right now know that there are disparities, differences in health outcomes for patients. We know that Black patients face higher rates of mortality at younger ages. We know that Black patients have higher rates of heart disease, have higher rates of chronic kidney disease. And so they ask, are the ways that we're using race worsening those outcomes, or are they improving those outcomes? And they say that if the way that we're using race allows us to improve access, allows us to get people treatments earlier, allows us to help ameliorate those disparities, then maybe it is appropriate. But right now, because it's this imprecise categorization that also worsens health outcomes for Black patients, then maybe we shouldn't. Does that answer your question?
A little, yes.
You had 3 bivariate displays there, about halfway through the talk.
Yeah. Mm-hmm.
On the left was sort of maybe 0.3, yeah. And then the one in the middle was a better association. What's the one on the right?
Yes, this one on the right is a little complicated. This one uses another marker called cystatin C. That's also related to kidney function. And there's a lot of people who are thinking about how cystatin C might help us better approximate kidney function. So they looked at how creatinine, which is that factor that comes from muscles, plus cystatin C, whether that would help us come closer to someone's true kidney function. And as you can see, there's pretty widespread. Their R was 0.03, so pretty far from 1. And so it didn't do super well in their study.
Without getting into the statistical weeds too much, you have an enormous variety of variables, as in any medical research, I suppose, and many kinds of research, certainly in education. How, and this might not be an easy question, but how do you go from this vast array of variables down to those 1 or 2 or 3 that you're reporting on in this display right here? How do you get from a huge barrel to just a few really interesting variables?
Yeah, I think that's a really good question. I'm actually going to show you a slide that I didn't include. Let's see if I can find it. So this talks about the origin of these equations, which I think is what you're getting at. Basically, what they do in these studies is they take a big group of patients, they measure their kidney function directly. So they use the gold standard of measurement, that thing that iothalamate that I mentioned at the beginning. And then they measure everyone's kidney function, and then they divide the group into 2 groups, a test group and then a validation group. And the test group, they use they measure a bunch of different variables: age, race, sex, weight, height. Things that I haven't included on these slides include like the albumin in their blood, their creatinine levels, the cystatin C, their hemoglobin, their urine output, all of these other factors. And then they use a bunch of mathematical modeling, which I won't get into because definitely not my expertise. And then they come up with an equation that best fits this original test population. And then sort of do away with all of the variables that don't seem to help fit that equation to the test population. Once they've come up with their set of best fit equations for that test population, they then use the equation on the validation population to see then if it fits them as well. And so they basically use this huge set of different variables, kind of guessing at what might end up actually affecting someone's kidney function. And then once they come up with that equation, we'll then test it on the test population. So whichever ones don't end up seeming to have an impact, they don't end up including in the final equation that they use.
So those 5 variables were the most powerful ones in terms of being associated with what you're looking at?
Exactly, yeah. So the ones that I mentioned that are included in the kidney function calculation right now, so age, race, creatinine, and sex are the ones that ended up in the equation. Those were the ones that they found with their population would give the best fit for their kidney function. A lot of people have written now about how their population is not representative of populations today. For example, they didn't, there were not very many Black patients. Many of the Black patients were in more labor-intensive professions where they might be, labor intensive such that it affected their muscle mass. And by affecting their muscle mass, it then affects their creatinine. Because creatinine, as I said, is a muscle breakdown product. And so when we're looking back at these original studies, there's a lot of people are saying, that doesn't really check out anymore. The justification for using a race variable might have been more related to these people's employment as opposed to some biological factor instead. I know it's 2:35 and I don't want to cut into Colleen's time too much. If there's any pressing questions, I'm happy to